Welcome back to Lesson 3 of this team course on dental occlusion. In this third lesson, we're going to spend some time talking about the correlation or the connection between occlusion and systematic or facially generated treatment planning. And again, when we look at those three circles with the patient, taking into consideration where they come from, and we've talked about doing our exam, this is that third circle that really is about how do we find out or come to the conclusion of what would be ideal treatment or optimal dentistry, and what role does occlusion play in that. As a team, you might be familiar with the term facially generated treatment planning and the four components of facially generated treatment planning: aesthetics, function, structure, and biology. As you can see, function in and of itself is a category by itself, and that's when we look at the joints and the muscles and the way the teeth rub against each other. It must be important because it's actually the second of the four. I'm not going to go over all the steps of facially generated treatment planning, but once we put the teeth in the right place, or we know where we want the teeth to be, so again, you can see this patient here where we're going to do some restoring of both anterior and posterior teeth, but the start is putting the teeth where they belong, which I won't go too into right now. But then we come to function, and when we talk about function, it's so that when we go to our models, we actually go to our models with some intention. And again, I know that you as the dental team are not going to be the one doing this, but I want to help you appreciate that when we go to the models, it's what we talked about in that first lesson, which is taking a look at where the dots are, right? And how the teeth are touching in the back, and how the front teeth are guiding. And so when we take the time to identify where the teeth should be touching and rubbing, by the time we actually come and do the dentistry, so the day that I placed the provisionals on this particular photo, it was really the second time I'd seen it, because I did it once on the models, and now I'm doing it in plastic, and I get to actually test drive my function because I spent the time treatment planning with the function. And by the time we cement or place the final restorations, again, it's aesthetically pleasing. The teeth are where they belong in her face, so I want you to see that. But they also function really well, and both in maximum intercuspation and when the patient moves her teeth all around, from side to side and from front to back. And this is how occlusion plays a role in, if we switch the words up a little bit, in predictable dentistry. So now let's play with words a minute. And when we talk about predictable dentistry, well, it's predictable when we are comprehensive or when it's really occlusion driven. And so part of our treatment planning process is making sure we specifically look at that functional aspect of facially generated treatment planning. So when we're treatment planning for the ideal, or what we think would be optimum, one of the questions we can ask ourselves is, well, if we're doing that, when would it not work? When would this ideal occlusion not be successful? So let's spend a couple minutes talking about the threshold of adaptability. And luckily, as human beings, we're all very adaptable. In other words, if one of my favorite examples is if I was to put a rock in your shoe and ask you to walk around, you'd do fine for a while because it's in this zone of adaptability. You would probably move your foot to one side, or you would step more quickly on one side, or you might even rotate your hip. You're very adaptable. And then there's this zone on the outside, which is really the danger zone when things aren't working. So when we think about that, if there's not a rock in your shoe, then you're right smack in the middle. Things are great. And if I put a rock in your shoe and you start to adapt, and again, you pronate your foot in a little bit or torque your hip out a little bit, you're still doing okay. You're still within that zone of adaptability. But if the rock's been in your shoe too long, then you're outside of that zone of adaptability, or that threshold of adaptability. And so now you are having some more chronic or acute even hip pain, or the rock has actually punctured the skin in your shoe. You're now not functioning very well. You're outside of your zone of adaptability. I want to share a case with you that encompasses everything we've talked about so far, that I treated probably back in 2002, maybe 2003, after I'd really incorporated a lot of what I learned, the same as you're learning, or you as a team are learning at Spear Education. And it was very individualized for this patient. It was appropriate, and yet, aesthetically it wasn't ideal. But what I want you to see is that I really focused on the occlusion. I put him in the middle of that zone of adaptability. And so when he moves his teeth from side to side, his his front teeth discollude his back teeth and they rub real nicely on each other, and when he bites together his back teeth touch real evenly and simultaneously, going from side to side. And he had been this way for 5 or 6 years, and every time he'd come in he would say how great his teeth were feeling and that he loved the way they looked, and of course I loved it every time he came in, because really, he changed, as you can see here, from he really loves his smile and he's functioning really well. And I had actually given him an appliance to wear at nighttime for protection, but he actually never wore it. But he hadn't been wearing it for the whole 5 or 6 years, and he'd been doing just fine. Until one day he walked in, and he had a chip of one of his front veneers, and one of the veneers on his premolars actually came off. And I would swear that the space behind one of the cuspids was starting to get larger. I mean, all in one foul swoop, as you can see here, there was a lot of breakdown. So, but why after 6 years did that happen? Well, it was because he had a big life change, and his forces were greater than all of that good work that we did back 5 or 6 years ago. Now, the point is that, yes, dentistry is still going to break down, but my main point is I did my best to start him in the middle of that zone of adaptability. If I were to start him on the edge of that zone or didn't really take all this into consideration, he probably would have broken down a lot sooner. And so I was glad that I knew that we started him in the middle. And yes, he still got outside of there, and that's part of dentistry. But if we think about occlusion and always starting people in the middle of that zone of adaptability by using our treatment planning, our systematic treatment planning process, our predictability goes up, our dentistry lasts longer, and our patients are a lot happier. So when we talk about that circle of optimal treatment, it really starts with, again, systematic treatment planning, facially generated treatment planning, and using all 4 of these components. But the role that function plays is critical, and again, it might even be more critical than the rest. So occlusion in your dental office, occlusion as an overlying aspect of predictable and comprehensive dentistry is something that I hope you got out of this course. And so what we've looked at is basically what is comprehensive or predictable dentistry and the role occlusion plays. How does occlusion play, or what is the connection between occlusion and our comprehensive exam? And what is the role of occlusion and systematic or facially generated treatment planning? And we also have a pretty good idea of what the components are of occlusion in the mascatory system. So again, a global view of occlusion for your dental practice. I hope it's been really helpful, and I'll see you at the next course. Thanks.